morning, good afternoon, and good evening, and welcome everyone to another edition of the IFA Global Café. So today I'm pleased to be joined by Ms. Sonia Hsiung, who is going to be speaking on supporting healthy aging through social prescribing. So loneliness and social isolation are significant issues among older adults, posing serious health risks. And research has shown that social isolation and loneliness can lead to higher risks of cognitive decline, depression, heart disease, and even early death. And these conditions are as detrimental to health as many other kind of non-communicable health conditions. Social prescribing has emerged as a unique intervention which can play a crucial role in mitigating these risks by promoting social connections and improving overall well-being. And so today we're going to talk about the history, the implementation, and some of the best practices associated with social prescribing, as well as some of the challenges and gaps associated with its current use. So today, as I mentioned, we have Ms. Sonia Hsiung, who is the Director of Community Health and the Canadian Institute for Social Prescribing, which is a national collaboration hub anchored within the Canadian Red Cross, dedicated to bringing people, practices, and research together to improve integrated health and social care. And with experience managing multi-sectoral projects in Canadian and international community-based organizations, spanning from healthcare, food security, housing, gender equality, and engineering, Sonia is keen to bring the strengths of diverse sectors together to build more equitable and connected communities. So Sonia, welcome to this morning's Global Cafe.
Thank you. It's such a pleasure to be here with everyone.
Mm-hmm. So we always kind of start at the beginning, Sonia, here in the Global Cafe. So really just interested in a little bit about your story and how did you come to kind of be involved with social prescribing in your role at the Red Cross currently. So I'm wondering if you could take us a little bit through your journey.
Sure. So it's quite a winding journey. Back in the day, I was originally trained as an electrical engineer. I realized that was in your introduction, that was may have felt like a strange add-in, but that was my background. I went to school for. And at the time, my school had this unique stream that was called Engineering and Society. So it was all about the social impact of technology and livable communities, and really was my first exposure to the world of community development, and just a bit of a flame for me around that. Nevertheless, I went into my field. I ended up in nuclear energy generation and had my life all planned out, as you do in your 20s. But that little flame around community was just still there. It just wouldn't die. So I went back to school for international community development. I worked for international not-for-profits for a bit, ended up in Toronto in inner city urban development, working in all sorts of areas. And then in 2018, I ended up at an organization in Ontario, Canada, that was a comprehensive interprofessional primary healthcare organization or network of these organizations that was leading what was then the first social prescribing initiative in Canada. So we piloted in about 11 community health centers, which is, for those not familiar, a very specific model of primary care that we have in Canada that was team-based care nestled within social care with a lot of wraparound resources that was serving primarily most vulnerable populations. And we saw just tremendous improvements to people's sense of connectedness, to belonging, to mental health. And the project wasn't focused on older adults necessarily, but it ended up that the people that were participating in social prescribing ended up predominantly being older adults. And so we saw a lot of impact in that. Along with that, this transformation of how the clinical providers within these settings viewed health and how it changed the way they connect with community, even within this model that was already quite advanced in its perspective and its view in providing holistic care. And so all the pieces of my journey just started to fall together at this point around the importance of connecting all the different pieces of work that I have been doing together into this pathway, into this um, connected way of looking at well-being. Um, the social prescribing movement grew in Canada at that point, and around 2022, the Canadian Red Cross was successful in receiving some funding from the Public Health Agency of Canada to start the Canadian Institute for Social Prescribing. And I came over here to continue to grow this work and see how I can contribute to that. And that's where I am now.
Thank you, Sonia. I think it's always really interesting to hear kind of people who kind of started out somewhere entirely different and then it all kind of fits together somehow. So thank you so much for sharing. And I'm wondering, I mean, you did kind of introduce this idea of social prescribing and its rise in Canada, but I'm wondering if we can really kind of hunker down and explain what is social prescribing for those who may not be familiar, and if you can explain maybe a little bit of the history of how this came to be an intervention, in Canada, but also abroad.
Of course, yeah, I see some familiar names in here, so I know that there are some of you who know social prescribing very, very well, and I look forward to that conversation that we'll have together and your thoughts in the chat on anything I might have missed.
Mhm.
We know that only about 20% of what keeps us healthy has to do with medical care, with that formal access to our healthcare system. The other 80% of our well-being is all social factors, what we call the social determinants of health, right? Our education, our income, where we live, the people that we have around us, our access to transportation, our ability to access good food, and so on. So the idea of social prescribing is very simple, is to offer a structured and intentional approach to connect people between the formal healthcare system and those social and community supports that are necessary for well-being. It looks different in different countries. It looks different even across Canada and our different jurisdictions, but there are a few core components that I would say makes it social prescribing as opposed to the other very wonderful models and approaches that exist in the landscape. So there's always an identifier. There is, and usually within health. And the reason we focus on health in social prescribing as the prescribing part of the equation is that that's often where the gap is. In communities, where communities are great at connecting people to each other. The health system, not so much. And so having an identifier who is leveraging a healthcare interaction as the doorway to identifying when something else is going on, something else that can be supported beyond medical treatments or that can complement and enhance medical treatments. And then being able to connect the person to a connector. So the term that's often used is the link worker. In Canada, we often like to call them community connectors. And this is the person that has more time, the person that has the community knowledge to be able to sit down, have a conversation, and connect the person further to those different supports that exist, journey alongside, help to address the different barriers that might arise. And then, of course, there's the social prescriptions. You need to have things that people can be connected to, and that can be anything from the material part of those needs, like groceries, housing, getting tax returns, or some accessing financial benefits, to things that are more emotional social supports, bereavement groups, caregiver support, and gardening, museum visits, volunteering, knitting groups. The possibilities are really endless. And in the social prescribing pathway, we're really agnostic about what prescription exists because it's focused on the person. So at the center is the person themselves, the patient, if we want to use the medical terminology. They are not a passive recipient of care. In the traditional health model, this is here's your diagnosis, this is what's wrong with you, here's your pill, and off you go. In social prescribing, the focus is on asking what matters to the person. It's reframing that conversation, looking at how we can co-create solutions together to help people reach their own goals. So it's a very strength-based, co-creative approach with that supported navigation piece that goes beyond information and referral. And oftentimes just meeting, just having that interaction with the connector is what makes people feel heard, what makes them feel seen, validated by a system that can often, you can feel very invisible in, right? And to encourage people to become more actively involved in their own well-being goals.
Mhm.
So there's a story that I want to tell, Katrina, if I
Yeah,
try to carry
absolutely.
on any time.
Yeah, please go ahead.
I won't be able to do this because, like, we live in stories. This is
Mhm.
what helps us put things into context. I won't be able to do this justice. It's a story that a physician in England really likes to tell, Dr. Marianne Essam. Some of you may know her. She was the early champion of social prescribing. She sees it as something that's the most transformative in her entire career as a primary care physician, as a GP. And this is the story that she tells. In her region, there was a gentleman who started showing up to their emergency room departments with heart palpitations. And of course, when you have heart palpitations, emergency is the right place for you to go. You want to make sure you're safe, especially with this as an older gentleman. But they started to wonder because he would show up week after week on a Friday with heart palpitations. So they connected him with a link worker, with social prescribing connector, to say, you should absolutely come to emergency when you have these heart palpitations, but maybe there might be other things I can support you with. Can I come for a visit? And it turned out what they had surfaced was that him and his older wife, they used to have this couch that they liked to sit on at the end of the day. They would hold hands, they would share about their day, and all will be right with the world. They're older now. They can't sit in this couch anymore because they can't get up after. And so they sit at their dining room table across from each other and they worry at each other. And the stress of the day impacts them. And this very creative connector went around to the community agencies, looked at all the resources, managed to get them a new couch. This gentleman has not had to visit the emergency again for heart palpitations. It's so incredibly simple when we think about this. And I know that's not new to most of you. People all over the world have been doing this in different ways, but it's not the way our health systems work. And in countries like England and Canada, we have relied so heavily over the last decades on this biomedical model of sick care. So we're focused on treating illnesses, but not on the health creation and healthy aging that takes into account all of those social aspects of our lives. We've divorced that into here's a little bit about your medical history, and then here's a little bit about your social piece, and then maybe here's a little bit about your finances, and not how it all come together in our lives. So social prescribing is really an antidote to that. It's arisen out of this need to reconnect all of those aspects. And as a specific term and this approach that I described, it really came out of practices in England in the early 2000s as a response to the healthcare crisis that they are seeing in the National Health Service in England, where there's that many of us are facing, where we just simply don't have enough doctors. Our emergency room wait times are atrocious, and our health systems are in financial crises. So in England, the early adoption was in primary care settings. That's not the only setting in which social prescribing can happen, but it was championed by the GPs as a way to better support their clients and alleviate the burden for their own practices. And that led to the establishment of the National Social Prescribing Network in the UK around 2016. And they were able to make huge strides. It is now integrated as an official part of the National Health Service long-term plan. I believe they have something like 5,000 official link workers funded by the healthcare system. And the goal is that every primary care team in England would have access to a social prescribing link worker to be able to socially prescribe. And the rest of us are catching up. It's now implemented in something like 31 countries around the globe, certainly in Canada, Australia, Singapore, Korea, and many of European countries and a few other places in the global south as well.
Mm-hmm.
So that's the journey we're on for this.
Yeah, thank you, Sonia. I think it's certainly, such an impactful story that you shared, and certainly feels like you're right. There is such simple solutions, and maybe we've tended to kind of over medicalize things in many of our lives and in our systems. But I want to ask, and you did kind of touch on this at the beginning, which is how older people are kind of specifically impacted by this loneliness and social isolation. And I think that this is something that, we all see in our daily lives, which is, people that are really just incredibly disconnected from community. And so, what kind of are the specific benefits that you see social prescribing providing to older people and to our ability to age in health and well-being, which is, contribute to this idea of healthy aging?
Hmm. Yeah, absolutely. So I think you prefaced it really well around the impact of social isolation and loneliness. Right? And in Canada, which is the context that I know better, I am more familiar with, we've had various reports about older adult and loneliness and overall Canadians and loneliness.
Mhm.
There was this Angus Reid report back in 2019 that I really loved, actually, that looked at, maybe we should talk about also just a reminder about the difference between social isolation and loneliness. I know we often use it in the same sentence, but loneliness is this a feeling of disconnection. You can be surrounded by people, but still feel desperately lonely, unseen, not understood. And then there is social isolation, which is not having a social support network, not having people that you can call, not having people that you would lean on if you needed something physically apart. And there are people who are socially isolated by choice, but who are not lonely. But though it is often can be an indicator of loneliness. So this Angus Reid report looked at all four facets: people who are lonely but not socially isolated, not lonely, who are neither, who are both. And it found that there's 23% of Canadians that fell into what they call the desolate category, which is people who are both lonely and socially isolated. And when we looked at older adults, there's definitely loneliness, and often with older adults, it's social isolation. So they may not feel lonely, but they are socially isolated, which still has, interestingly, a detrimental impact on their health. And we have in Canada lots of older adults that move out of the cities into more rural areas to retire, and then they would lose a spouse. Their children are far away, and the people that, their normal support network would be far away. The hospital is far away. And then when you lose your ability to drive, transportation becomes an issue, and then people become housebound and extremely socially isolated. So that's the challenge we have, part of the challenge we have here in Canada. And so social prescribing offers a lot of those pieces that can reconnect people. So the obvious one is, of course, the social connections, right? There's activities, programming, exercise groups, hobbies, hobby class, friendly calls program virtually as well, that can connect people into a social network. And then there's also those uh, physical activity pieces where you can sneak in the social aspect, which is quite interesting. So we have this person who was part of a social prescribing program, and they said to the connector, I just want to exercise. I'm not interested in the social parts of this. I don't need to be connected with people. I just want to do something to improve my physical health. Got connected to a yoga class. And when we follow back up with her, she said, actually, I stayed in this yoga class because of the friends I made. Actually, it wasn't the exercise that was most important to me. I didn't realize this, but it was the social connections. And you can also do the reverse, where you can use the social connections as a way to support the physical health of a person, because then we also have an older adult who is advised by their physicians to exercise to help manage their diabetes. And he was connected to one of our connectors back in our pilot. And he said, I don't want to join this walking group because I'm a slow walker. I don't want to be judged. I don't want to slow anyone else down. And I'm just not comfortable going to this walking class and walking group, sorry. And the connector went with him for their first few walks to help him be comfortable, make some connections. He found someone that walks at the same pace as him, and now they're walking buddies. So there's different ways in which it all comes back to the connection, but there are different supports that it provides to older adults that is connected to the other areas that would improve their well-being and to help with that healthy aging. And the that independence and autonomy is important, where I talked about transportation. Like that's often a precursor to being able to participate in different activities. So this is where that supported and tailored navigation is quite important, because you could say to an older adult, do X, Y, and Z, but that's not particularly helpful if there are some barriers in the way, whether that is a physical barrier or that's an emotional barrier. And so that support and in terms of the navigation and asking what matters to the person is often really important, because we can also look at people and say, yeah, you should join a coffee club. But maybe what people are really interested in is art, which is what we have seen. And we also have one gentleman very early on, one of our first pilots, who was just interested in fishing. Like that was something that he had loved for his whole life, was not really able to do anymore. And what the prescription was to match him up with a fishing buddy, and they go fishing together. And that's what he needed. That was a connection. It wasn't a big social group. So it's so individual to the person on what they want, what they would appreciate, what would bring life back in for them. And that's that supporting piece of importance. And then the co-creation, because in many of our places, what is appropriate may not exist. And certainly in rural areas where there are less services, that is true. And so inviting people in to co-create together and consider the art of the possible is also very important, instead of saying, well, we don't have an art class, we don't have a knitting group, or we don't have a bereavement support that will help you, so find something else. We have seen people be supported to lead a bereavement group, to start a cancer support group for other people. And that's a very important piece as well of beneficence. We know that's so important to people's sense of purpose, which people often lose after they retire or have a bit of loss around, and to people's sense of self-confidence. Older adults have so much to give. There's so much experience. They often have time as well. And being able to connect and enable people to give back is a benefit to our communities as well, and grows that stronger network. There's just this group of francophone older adults who are who are patients of a community health center. They formed a social prescribing champions group, so for social connections, and they have this. They wrote this letter that I absolutely love, but in it, what they basically said was helping others help themselves to deal with and fight their social isolation and loneliness, and was putting life back into their lives. And that was a model that I really loved about this.
Mhm. Yeah, thank you so much. I think that's a great little line as a takeaway and how it kind of gives purpose back to people as well. So there's actually quite a lot going on in the chat. So I'm gonna turn my attention over to some of the questions and comments. There's also quite a lot of comments that I think might be interesting to get your perspective on, Sonia. So maybe I'll just start here. We have a question from Shmuel, who is a weekly contributor at the Global Cafe. So um, they're asking, how can social prescribing support healthy aging for poor and low socioeconomic groups of the population? Oh, you're muted, Sonia.
Thank you. That is
Mm.
a fantastic question because that is the primary focus of people. Social prescribing, of course, it's for everyone, but there are the people who tend to be able, who could use a little bit more of that support are people who have barriers in accessing care and accessing social and community supports. There are people who don't need social prescribing. They're just connected to all of the community supports or have the ability to pay for different things that, and they don't need social prescribing. So in all of the work that is happening in social prescribing across countries, um, the people that tend to be participants are people who are facing some of those barriers, whether that's because of structural challenges or personal um, uh, situation. And so there's social prescribing in general prescribes to or co-creates activities that are free for access, and then tries to address things like transportation that would be general, that could be a cost to people who don't have access.
Mhm. Great, thank you. So I'm gonna go to another question here from Isaac, who's asking, what role do you think digital technology can play in social prescribing, and what might be the positive and negative impact?
Mm-hmm. Yeah, I really, digital technology is the sort of new frontier, right? There is a huge role for this to play in multiple ways. So one of the things is the connection, the pathway of the connection. Because the communication between health and community is not great. It within health is great, within community could be okay, but when you start to cross sectors, it breaks down. And then that's not even talking about the other sort of non-traditional prescriptions that we would think of, like arts, nature, and so on. So there's a huge role around that connective pathway. There's also a piece around mapping community assets that everyone struggles with within this, because you've got to know what exists in your community. And some of those things can be really hard to surface and hard to keep track of, to know what exists out there. And then certainly in evaluation and in understanding things like who is, like a predictive model of who is most at risk, what works best for whom and when. So there's lots of places in which technology has not been, I would say, fully utilized in the social prescribing pathway, and it can be. The risk, I would say, is when for me personally, is when we see it as a replacement for social connection. So we've had interesting conversations with around things like a chat bot, or around having that be a replacement for a human connection. And so that, I think, is the risk. I think technology is a tool. It's not a replacement for our community.
Mhm. Mhm. Yeah, I think that's, a really important distinction. And then just because you mentioned this kind of chat box idea, have you seen that implemented in use? And what do you think of that? I guess is my question because maybe it's a little bit. I think it's certainly new and innovative, I guess,
For
but,
sure.
to your point, I think that human connection, you also don't wanna lose the importance and the
Yeah.
value of that human connection.
Yeah, it's interesting. So I've seen it in at least two different ways. I'm sure there is more. But one way is using it as a starting point for referral. You know, like now when you try to access your utilities company or something, there's this AI chatbot. Like, how may I
Yeah.
redirect you? So I think there can be something to that. I think that it's a really useful triaging support to start to get people to resources,
Yeah.
and to get to maybe the right connection. I think that very helpful.
Mhm.
And then there is that second part where it is sort of, here's your AI friend. Here is the
Mhm.
person who can accompany you. So it's really interesting. I've read some articles around that being used almost like Alexa or Google Home, where
Mhm.
you could talk to it, it talks back. And there is some research about it alleviating a sense of loneliness. But the research was fraught because it's a research. So you have a researcher calling this person, and you're trying for the researcher to not actually become the connection for the person and have that fidelity in research. But I would say for me, the evidence is not quite convincing yet around whether that could actually be a replacement. And my intuition would tell me no.
Yeah. Yeah. Well, thank you. I was just a little bit of a one-off that I was curious about since you mentioned it. Okay, so I'm gonna again go back to the chat because we do have some more questions and comments. We do have kind of a longer comment question from Elizabeth, Elizabeth Mills. Do you want to unmute and pose your question?
Thank you very much indeed. I'm chairman of Home Share International, which is the organization which promotes the concept of the exchange of housing for help. And I simply wanted to ask whether you, Sonia, or anybody has any experience of home sharing becoming part of social prescribing. In other words, to engage older people with younger people in order to
Mm.
help those younger people to provide them with affordable accommodation and create links. Because it's not just older people who are lonely and socially isolated. The, the evidence is very clear that younger people also suffer from loneliness and social isolation. And intergenerational home sharing can be a really good solution for those people. I just wondered if that had come across your threshold, Sonia, or anybody else's. I'm from Oxford, UK, by the way, but my organization covers the entire world.
That is very interesting and very unique. I have to say, I haven't heard about it. Not and certainly my knowledge is limited in this area, so not to say that doesn't exist. I think we have many people who are looking at certainly housing. So we have a housing crisis in Canada also, and also looking at more so around a neighborhood. So we have several sort of very interesting initiatives in Canada that's looking at, for example, natural retirement communities, or other sort of neighborhood-wide um, interconnections. How do we get neighbors to better connect with neighbors, but not so much the intentional home sharing, as far as I'm aware. There are some intergenerational social prescribing work that is around, you know, connecting older adults and younger people around different activities, mentorships, supports. We have one that was having younger folks teach or have some computer literacy classes with older adults as well. So I definitely think it's an area that we need to explore more, because the other big emerging piece, along with older adult social prescribing, is children and youth social prescribing. And aside from homes there and loneliness and social isolation, there is a mental health crisis happening within our young adults. as well. So I think that sounds like a beautiful way to knit those two things together.
Okay, I'm gonna go to another question, kind of comments in the chat. Jane Teasdale, I see that there's I think a question, also some few comments. Did you want to unmute and share a
Yes.
little bit?
Good morning. Can you hear me okay?
Yes, we can. Good morning.
Yeah, so hi, Sonia. Um, so Mosaic is part of Alliance for Healthier Communities, and they are doing some amazing work. I put some comments in there as well, but I wanted to ask Sonia, how do you feel the importance, I think, of person-centered care and training to professionals, managers? I think in order to understand social prescribing, community agencies and organizations need to understand, educate themselves, look at research on person-centered care. So just wondered if you have any advice or information on that and what you think.
Hi, Jane. So I've known Jane for quite a few years now, and they're doing great work in Mosaic for sure. And yeah, absolutely, Jane. I think person-centered care, I would say, is the big umbrella. I think person-centered care includes several other things, but within that, social prescribing, the whole idea of asking what matters to you is that we're putting the people at the center and not the processes, not the systems, not the assessments or diagnosis. It is what matters to a person, and it is a great tool in the toolbox around achieving more of that person-oriented, person-centered care, as well as the interconnections in the community. And really, really fantastic point about training, because our health systems, our physicians, our clinical providers have been trained in this biomedical model. I mean, that this is what they think about. And some of them are fantastic champions for this social intervention, social aspects of care, but some of them would say, this is not my job. This is not my role. Why does it matter to me? And I know, Jane, you are doing fantastic education around. So for our education at CISP, we look at two different areas. One is workforce development, which is training for existing, not just health providers, but also community providers. What does it mean to be better connected with the healthcare system? What does it mean to leverage that as a way to identify and catch people who may be falling through the gaps, and be better connected as well, because we also tend to work in silos in the community. And then the other part is curriculum, academic curriculum. How do we reach the next generation of our leaders? Because it's easier, frankly, to shape your mindset and to look at things in different ways earlier, before they've become steeped in this prescriptive model of, like, if they present with A, I will do B, and so on. So how do we reach people in that space? So we're looking at family medicine curriculum in Canada, as well as pharmacy curriculum. And in England, they've been quite successful in embedding social prescribing into all of their medical schools. I think it was 40-something medical schools in England. And they've embedded that in there. So we have work to do, and the rest. Well, Singapore actually has newly, within Duke University, embedded social prescribing into their family medicine curriculum as a new and evolving thing. So I see hope.
Yeah, thank you so much. And I think maybe just a kind of related question, since you're talking about kind of the workforce around this, Sonia. So we did have a question from Margaret that just says, talking about how social prescribing kind of requires many navigators and things like that. So maybe just a question on that, and Margaret is asking, is there follow-up on the way that the prescription is filled, following up over time? Are people kind of paid to work as these navigators? So maybe can you share a little bit more light, and how do we get people into those types of roles?
Yeah, so navigators are generally a paid position. And so we have seen initiatives that are testing out volunteers as the navigators, but there is, which can be really great for certain pieces, or a combination of volunteer and staff, because there is a level at which the volunteers can support, and then there is a more, say, wraparound level in which you really would benefit from a dedicated staff. And what has been found in research, primarily out of England, is that the navigator role is critical in supporting people to achieve the outcomes that we want to see. And in England, they've basically injected the system with this new role and new profession, if we want to call it that, of link workers. In Canada, we have some initiatives that are hiring on these new roles out of various pockets of funding. There is also, within our particular landscape in Canada, a lot of roles that are doing things that are similar. So there are systems navigators, there are care coordinators, there are senior, I saw Connie on the line. Connie, if you want to put in the chat on what they're called in Manitoba, like seniors support people. And so there's actually lots of people that that sort of exhibit similar places that perhaps we just need a bit of an extra step to help knit people together, and a little bit of that foundational common understanding of the work that people are doing. So I think that within our system, there's actually a lot of existing assets that we can leverage. And there's also perhaps a shifting of resources that can happen, because what we've seen is when we support people in the community, in their homes, it reduces cost in a more expensive part of our system, which is acute care. And so there's different pieces, I think, that of the puzzle that can be shifted around.
And then maybe just another question on kind of the follow-up. So are those navigators also involved in follow-up? So,
sorry, yes.
Yes.
Of course,
How
yes.
I think that's an interesting point as well, because how do you ensure that people, get connected to the right resources and also continue to benefit from the community services being connected to?
Absolutely. So idea of the navigator is a person that journeys with for a time. So it's not meant to be a permanent relationship in a person's life, because the goal is to have the person reconnected into their community, have that confidence to self-navigate, and be empowered to be their own active agents. Right. And so some people need a little bit longer support. Some people just need very short support. The models look different, but a typical model, a common model, would look like, for example, the person is connected with a navigator, and it's 6 to 12 weeks that the navigator or connector will follow. Maybe they'll have a weekly meeting. Maybe they'll have more frequent meetings at the beginning and less later. Go with people to activities if that's what they need, create sort of some plans, some goals together, and then follow up with them until such a time when the person doesn't need the navigator anymore, because they are thriving in the different aspects and being reconnected to people and communities and supports. So the follow-up is important. The evaluation part is extremely important, and as well as the follow-up, because it's not a one and done. It's not a prescriptive list, even though we're using the word social prescription. It's not here's a list of 5 activities for you to do, 5 people you should call, and that's it. It really is a journeying with for a time, with the goal of independence.
And then I think, I'm glad that you mentioned kind of this kind of evaluation piece, because I think, one of my questions is how do we build more willingness, amongst decision makers and things like that, to actually implement more programs like this, fund more community service type of programs. And I think that evaluation piece, I think we know, and maybe a lot of people that are interested in this may know, that this does have kind of indirect cost savings or things or efficiencies on our healthcare systems and broader social care systems. But how do you kind of build that willingness to have programs like this available?
So there's a few things. I've had some interesting conversations in our work around evaluation and framing. I would say in community, sometimes there can be this discomfort of using the health system or government priority language because it can feel a bit icky. It can feel like we're reducing people to numbers. It feels like we're selling out. But we do need to speak in a language that other people understand beyond our sector, right? So we often talk about our work in Canada aligning with the quintuple aim. And so the quintuple aim is the language of our healthcare systems at this moment that is around population health, improving care experience, improving care team well-being, health equity, and reducing cost. So when we frame the outcomes of our social prescribing initiatives in this way, it speaks to the decision makers who are using this type of framework, and not everyone is. The other emerging piece of interesting framing is around labor force, sort of economic improvements to the society and to the country. So we engaged KPMG, which is a consulting firm, international consulting firm, to do a rigorous modeling and projection using international evidence and Canadian data on what could be the economic and social return on investment if we were to implement social prescribing in Canada. And the modeling suggests that investments, every dollar investments can return $4.43 through improved well-being and reduced cost on the health system and on government. So those are things that we're using to understand our outcomes as it relates to other parts of the system as well. And now we're increasingly looking at, I think I saw just a sort of pop-up flash out. We're looking also at caregivers as an important unpaid support that our system is relying very heavily on. And so, what is that? Supporting the caregivers themselves as they support the people they're caring for is a very important part. And we're looking at what does it mean to measure evidence in this way. And it's a little bit difficult because people are not numbers, and there's lots of unintentional outcomes of social prescribing because it's so fluid and it's so tailored to each person. But there are sort of big ways, I think, that we can map our outcomes. And I think it's also important for us to come together with our evaluation and have a common language, a common narrative, which is often a hard a piece for governments to understand. When you think about community, it's just this massive, wide, diverse thing. And so we need to help our governments and our policymakers understand the possibilities and the potential.
Mm-hmm. Yeah, and I think even going back to that story that you gave in the beginning, right, is there an opportunity, where people are being filtered into healthcare services when really what they need is community services and social care services.
For sure.
Yeah, I think that's really interesting to hear kind of how you're putting together that case. Okay, we're coming to the end. But I want to try and squeeze in a couple more questions here, because something I know that was kind of very interesting to me, which we discussed when we met in preparation for this session, was just, some of the best practices that are happening kind of around the world as we see social prescribing become more readily available. And, we were talking a little bit about the difference between kind of high income countries and having social prescribing in low and middle income country kind of settings. So I'm wondering if you can share a little bit, what are some of the differences that you see in these different contexts and how kind of community plays a role?
Yeah, so there is so much work happening internationally. And this is an area where I think low and middle income countries are doing better. I think there is much more recognition of the need for community to come alongside in the absence of big government infrastructures and big government, I would say, funding to do things that way. So communities have come in to fill the gap. And there is stronger, I believe, social networks and that collaborative approach and that understanding of local adaptation. Whereas in some countries like Canada and England, our systems have become so siloed that we need the structured approach called social prescribing to help bridge some of those gaps. And in other countries, there are work happening that is very similar, just not called social prescribing. So at our, we had a social prescribing conference in Canada last year, and we had fantastic professor from Brazil who was talking about their community worker model and how that is leveraging peers and people who are in the community, know their community, to reach out and to be those connectors. So those, and they're not called social prescribing, but it is a very similar model, a similar approach. And in England, I would say one of the challenges, they have come far along enough in their social prescribing journey to see where some of their gaps are, in that they implemented social prescribing in this top-down approach, right? It was the health system, money into link workers, connected to the health systems, trying to connect people to community without investment in the community. And now they're seeing what my colleague really like to say, they have so many travel agents, but not enough vacations. They don't have the supports in the community to have people participate in. And that hasn't been a focus, and now they're pivoting. And so in Canada, we've done the opposite. We're doing the grassroots approach, community up. That this challenge here is we need to get systems buy-in. We need to get that investment that we don't have yet in terms of a systematic kind of investment or approach or standardization, but we have wonderful community and local adaptations that we're learning from. And so there's lots that we can learn from low and middle income countries around how the community networks are formed, and how how that, I would say, community development work is happening as well, whether they are called social prescribing or not.
Yeah, thank you. Thank you so much for sharing that. And again, we're just in the final kind of minutes of our session. So I am going to just give you a few moments, Sonia, to formulate some key takeaway messages for our audience. We've had such a robust engagement in the chat as well. So maybe there's an opportunity to kind of share that with you and share that with the group after the fact, because there's been a lot of people also sharing kind of resources and insights as well in the chat. But I will just take a moment to introduce our next week's speaker, and then Sonia will come back to you. Okay, so next week for our Global Cafe, we're really pleased to welcome Dr. Stephen Verderber, who's going to be talking about equitable places for older persons to live and recent advances in evidence-based architecture, which should be really interesting, in light of even our discussions today and talking about affordable housing and things like that, and different housing models that may serve older adults. So I hope that you all will join us for that session next week. All right, Sonia, I'll give the floor back to you for some final key takeaway messages.
Yeah, thank you so much for the robust conversations and engagements. I'm sure we didn't get to everything, and I would love to continue the conversation with everyone. I think perhaps I'll just end with, social prescribing is an international movement now because it is an approach and structure that can be applicable and adapted to many contexts to support healthy aging, and that it might already exist under different names in slightly different ways within your context. So it's a tool in our toolbox, and I would love to see us develop a bit of a common lexicon around this so that we can work together instead of in silos around this urgent need and very critical need for us to bridge our health and community care sectors.
Thank you so much, Sonia, and a hugely interesting topic. And I think everyone on the line has been, so engaged and so interested to learn more about this. And I think it's truly exciting to see this grow, and hopefully we do see it grow in Canada and abroad. So thank you everyone for our Global Cafe participants that have been hugely engaged in asking questions and putting insights into the chat. And so grateful for everyone for being here with us week after week. And thank you to the Global Cafe team at IFA as well that works to put on these sessions every week, particularly Luana Kalnago, who's on the line with us every morning. And yes, Sonia, thank you so much for joining us. Such a great session. And, hopefully there's opportunity to connect again on this topic.
Yes, thank you so much.
Wishing everyone a really great weekend. Thank you.